want to go ahead and introduce our speaker. And well, I guess first of all, welcome all of you to the September 2024 edition of the Advancements and Breakthroughs in Andrology Conference. And we're so thrilled to have joining us today Dr. Kian Asanad, who's an assistant professor of urology at the University of Southern California. And he's going to speak to us today about fertility-sparing exogenous testosterone therapy and alternative strategies for men with unique clinical challenges. Certainly a really important topic, and one that I think all of us that take care of men looking to preserve their fertility encounter. Dr. Asanad is from Southern California. He earned his medical degree from the University of California at Los Angeles, and then went on to do his residency at the University of Southern California. And we were really grateful to have Dr. Asanad join us here for our Andrology Fellowship just last year. He finished up with us at the end of June 2024 and went back to USC to join the faculty as an assistant professor of urology, where he's already quite busy with his clinical practice. So he's the director of male infertility and male reproductive medicine at the University of Southern California, and does have a clinical space in Beverly Hills, I would point out. So we're delighted to have Dr. Asanad join us today. And with that, why don't you go ahead and share your screen and we can get going. Thank you.
Thank you so much. It's really a pleasure to be back with all of you. So the title of this presentation, as you mentioned, is Fertility-Sparing Exogenous Testosterone Therapy and Alternative Strategies for Men with Unique Clinical Challenges. I have no disclosures related to this presentation. There's 4 key objectives of this talk that I wanted to highlight. So the first is I want to review the impact of exogenous testosterone on the HPG axis. We'll review some of the alternative testosterone therapies and their associated mechanisms. We'll discuss some data on combination treatment with exogenous testosterone and alternative therapy. And then I'll present a few unique clinical scenarios that may warrant combination therapy. So, I was fortunate to publish this opinion piece with Dr. Brannigan in the Journal of Sexual Medicine in June of 2024. And it really provides an overview and is the impetus for today's talk. But I'm hoping to take a deeper dive in some of the more granular details. So let's get into the background. Just briefly reviewing the hypothalamic-pituitary-gonadal axis. As we know, the hypothalamus secretes GnRH, or gonadotropin-releasing hormone, in a pulsatile manner that stimulates the anterior pituitary to release LH and FSH, and the LH stimulates the Leydig cells in the testicle to produce testosterone, and as we know, the FSH stimulates the Sertoli cells to produce sperm. When exogenous testosterone is administered, it causes a negative feedback to the level of the hypothalamus, which causes decreased secretion of GnRH and subsequently downregulates the LH and FSH and impairs endogenous testosterone production and sperm production. And why is this important? Well, testosterone prescriptions are incredibly common and are rising. In this research letter published in JAMA back in 2018, they looked at total and new testosterone use among men over the age of 30 between 2002 and 2016. They used data from a commercial health insurance database of almost 10 million men from these years, and they were specifically looking at changes in prescriptions after the FDA warning regarding testosterone safety in 2014. But you can see here in the yellow curve, in terms of new users, there's a significant increase in testosterone rates of prescriptions from about 0.3% in 2002 to 1.3% in 2012. Well, how is this relevant in 2024? Well, we have seen a plethora of direct-to-consumer men's health brands in the past few years, making it rather simple and straightforward to get testosterone for men with very little oversight. And so one such company here is called Hone Health. There's another one here called Henry Meds, Alpha Hormones, Fella Health, really highlighting making TRT readily accessible to the consumer. Highlighting this point even further of how direct-to-consumer testosterone therapy platforms are common and not necessarily prescribing testosterone according to published guidelines. As many of you know, Dr. Justin Dubin, one of our former fellows, along with the rest of the team, Dr. Halpern, published this paper in the JAMA of Internal Medicine in 2022, where they performed a secret shopper study where Dr. Dubin pretended to be a consumer with hypothetical symptoms and a normal testosterone level, gauging the practice patterns of the platforms. And he found that if he reported a testosterone level of 675 and that he was interested in maintaining his fertility, he was still offered exogenous testosterone by 6 out of the 7 companies, or about 85%. And about half of them had a treatment goal for him of over 1,000 and did not discuss the fertility risks related to exogenous testosterone. But unfortunately, there is data that even urologists would prescribe testosterone to men desiring fertility, and it's not just a direct-to-consumer issue. This is a study published with Dr. Brannigan colleagues back in 2012 in the Journal of Urology, where they looked at empiric medical therapy for idiopathic male infertility. They had 387 urologists who responded to the study, and about a quarter said they would treat infertile men with testosterone while they actively pursued pregnancy. There was a follow-up study to this more recently in 2020 with my partner, Dr. Semplaski, as well as Dr. Brannigan and others. And really the data was unchanged 8 years later. Still, a quarter of urologists reported they would use exogenous testosterone to treat male infertility. So this is clearly a problem. On the flip side, from a fertility standpoint, men are becoming more and more invested in their reproductive health. Fertility discussions are becoming less taboo, and there are several direct-to-consumer at-home semen test kits available. And so therein lies this slippery slope of men aiming to optimize their testosterone while maintaining their fertility potential. Well, what do the AUA guidelines state? Well, the AUA guidelines on the evaluation and management of testosterone deficiency state that exogenous testosterone therapy should not be prescribed to men who are currently trying to conceive, and that's a grade A level recommendation. Clinicians may use aromatase inhibitors, human chorionic gonadotropin or HCG, as well as selective estrogen receptor modulators, or a combination thereof in men with testosterone deficiency desiring to maintain fertility. So let's briefly review what some of these agents entail and their mechanisms. So the first is clomiphene citrate, or the brand name Clomid. Clomid causes an inhibition of estradiol at the level of the hypothalamus, which subsequently causes an upregulation of GnRH and subsequently LH and FSH, which stimulates the Leydig cells and Sertoli cells to improve endogenous testosterone production and sperm production, respectively. Secondly is a class of aromatase inhibitors, or anastrozole, which inhibit the enzyme aromatase, which is primarily found in adipose tissue. And aromatase is an enzyme that is responsible for converting testosterone to estradiol. And so when you have an aromatase inhibitor on board, there is less conversion, so there is a higher testosterone to estradiol ratio. And in turn, this decrease in estradiol also feeds back to the hypothalamus, causing an increase in LH and FSH production, again, further improving endogenous testosterone and sperm production. HCG is an LH analog, and so the HCG or LH directly stimulates the Leydig cells, which improves endogenous testosterone production, which in turn also supports sperm production, especially if there's testosterone deficiency. So let's jump into a few cases that can highlight some of these points. So the first is a 33-year-old male. He presented with a history of testis cancer to us, and he had undergone a left radical orchiectomy. He had undergone 4 cycles of systemic therapy, including BEP 3 years prior. He's had no evidence of relapse. He was there with his partner, and they were unable to achieve a pregnancy for the past year. He had a semen analysis performed 3 years since his systemic therapy, which demonstrated normal volume azoospermia on 2 different samples. Subjectively, he had a severe lack of energy. He reported a very low libido, and he had some erectile dysfunction. On exam, he had a solitary right-sided testicles, about 18 cc's. He had a palpable right vas deferens, and there was no varicocele. In terms of his hormones, his LH and FSH were significantly elevated. His LH was 34, FSH 45. His testosterone was severely low at 152. Estradiol and prolactin were otherwise normal. So in terms of his treatment options, and we think of the alternative options, we think of Clomid, HCG, or anastrozole. I would argue his LH is already significantly elevated at baseline, and there may not be much of a testicular response. The patient is not significantly overweight and may not necessarily benefit from anastrozole or an aromatase inhibitor, so I would opt to choose him with HCG. So you prescribe him 2,000 units of HCG 3 times a week. He comes back to see you about a month later with a repeat testosterone level, and his testosterone is still low at 185. He has persistent hypogonadal symptoms of low energy, depressed mood, fatigue, and low libido. So we serially increase his HCG to 2,500 units 3 times a week. He comes back again to see you at 8 weeks with a repeat level. Testosterone is mildly improved, but he's still severely symptomatic. You increase his testosterone dose, his HCG dose to 3,000 units, which is typically the maximum HCG dosing 3 times a week. Again, he comes back to see you at 12 weeks. His testosterone is still low at 235, and he's persistently symptomatic. So what would be the next step in this patient? I would argue I would start him on a combination of testosterone gel and HCG 3 times a week. He comes back to see you at 16 weeks. On dual therapy, his testosterone is almost 500, his symptoms are significantly improved, and he feels like, in quote, a new person, he tells you. You see him at about 6 months. He's persistently azoospermic despite normal testosterone levels. We took him for a fresh right-sided microtessie. Unfortunately, we had no sperm found, with final pathology demonstrated Sertoli cell only. The couple ended up using donor sperm as a backup, and the female partner was at the end of her 3rd trimester. The patient was incredibly grateful, and he was excited to be a parent. So where does this data come from to support this sort of combination therapy? Well, there was a landmark paper published in JCEM back in 2005 looking at the addition of low-dose HCG on intratesticular testosterone production in men on exogenous TRT. So they looked at 29 men. The average age was about 24 years with a range of 18 to 41 years. And they randomized them to 4 different treatment groups. The first was 125, 250 or 500 units of HCG compared to saline placebo every other day for 3 weeks in conjunction with 200 milligrams of intramuscular testosterone ethynate weekly. They measured intratesticular testosterone levels via percutaneous aspiration, and they did this at baseline and at 3 weeks. Then you can see here on the histograms on the left, men who had received 500 units of HCG 3 times a week had the highest intratesticular testosterone level compared to the other groups, even in the presence of exogenous testosterone. And just to recall, they were getting 200 of testosterone weekly, which is a pretty hefty dose. On the right, you can see there's a linear increase of HCG as the intratesticular fluid of testosterone increased as well. It's important to note that the endpoint of this study was not sperm counts or semen analysis, but nonetheless, the maintenance of normal intratesticular testosterone might help still support sperm production. And so thus, the combination of exogenous testosterone with 500 units of HCG 2 to 3 times per week may be a potentially fertility-sparing exogenous testosterone therapy for men who would benefit, such as this case. The next case is an 18-year-old male who comes to see you. He has a history of Klinefelter syndrome, and he presents with poor puberty progression. He was not actively trying to achieve a pregnancy. He denied any real issues with erection or ejaculation. On exam, he had a tall stature, he had some mild gynecomastia, and he had atrophic 6cc testes bilaterally and had Tanner stage 2. In terms of his hormone panel, his LH and FSH were significantly elevated. His LH was 27, FSH was 32, testosterone 188, estradiol was 52, prolactin was otherwise normal, and he had 2 different semen analysis which showed normal volume azoospermia. So looking at the treatment options for him, again, I would argue Clomid may not be very effective for him given his LH is significantly elevated. And as you may notice, his estradiol level is high and he has some kind of gynecomastia, which is pretty classically seen with some men with Klinefelter syndrome. And so I would argue I would start the patient on anastrozole. So you start him on 1 milligram of anastrozole daily. He comes back to see you at 4 weeks with a repeat testosterone level, and his testosterone's 210. So it's not at goal of 300, and his estradiol level had improved to 33 from 50. What would be the next step for him? I would argue you could start him on combination testosterone gel and anastrozole 1 milligram daily. He comes back to see you at 8 weeks with repeat hormone panel, and his testosterone level is at goal over 365, and his estradiol level is 23. So where does this data come from? Well, Mehta and colleagues looked at sperm extraction in adolescents with Klinefelter syndrome with 1 year of combination topical testosterone and an aromatase inhibitor. It was a small study. They looked at 10 adolescents with Klinefelter syndrome with testosterone deficiency and had a testosterone to estradiol or TE ratio less than 10. And the main objective was to evaluate surgical sperm retrieval rates in these adolescents with Klinefelter syndrome and testosterone replacement therapy. In terms of their cohort characteristics, you can see here for the 10 men, patient age ranged from 14 to 22 years, with average age being 15. The mean baseline testosterone level was 192. The mean baseline LH and FSH was 8.5 and 18.5 respectively. All patients notably had a TE ratio of less than 10. And you can see here all the way on the right, they had sperm retrieved in 7 out of 10 of the adolescents, or 70% successful sperm retrieval rate. And so they concluded that spermatogenesis appears to be maintained in the majority of patients based on the small study using this combination therapy. And so thus combination of a topical testosterone with an aromatase inhibitor is a potentially fertility-sparing exogenous testosterone therapy regimen, which may be considered especially for men with Klinefelter syndrome and or men with a TE ratio of less than 10. The third potentially fertility-sparing exogenous testosterone treatment option is a medicine called Natesto, which is a short-acting nasal testosterone gel. This was published in JU most recently in 2020. This was a single-center, open-label, single-arm trial. And they hypothesized, based on the frequent dosing and short-acting nature of Natesto, that it mimicked more the physiologic levels of testosterone release compared to some of the more long-acting testosterone therapies. They hypothesized that this would help preserve and maintain the central gonadotropins. They did this study between 2017 and 2019. They had about 60 men enrolled in the study. They had 73% follow-up at 3 months and about 55% follow-up at 6 months. Average ages of men in the study was 18 to 55 years. In terms of their cohort characteristics, you can see that more than half of the sample was Hispanic. Average age was about 37 years. The average testosterone level at baseline was 231, and the average total motile sperm count for the cohort was about 43 million. In terms of their testosterone, LH, and FSH levels, they saw a significant increase in total testosterone from baseline, with over 90% of the sample achieving therapeutic levels over 300 at 6 months. And as we expected, there was a significant decrease in LH and FSH, and 14% of men had undetectable gonadotropins at 3 months. In terms of their sperm counts, they did notice a decline in sperm concentration and total motile sperm count, but this was a non-significant decrease, with an average decrease of -4 at 3 months and -5 at 6 months. They reported one patient in the study was azoospermic at 3 months, and this patient ultimately dropped out. 3 patients, or 5% of the sample, became severely oligospermic, and they persisted in the trial. And so the take-home messages from these 3 studies is, number one, the combination of exogenous testosterone with HCG concurrently 2 to 3 times a week is a potentially fertility-sparing exogenous testosterone therapy. Number 2, we can integrate combination of exogenous testosterone with an aromatase inhibitor or anastrozole 1 milligram daily. Short-acting intranasal testosterone therapy or Natesto 3 times per day could also be considered. But it's important that we proceed with caution and know the limitations of the studies. And so really the data surrounding the combination of topical testosterone gel and aromatase inhibitors, as well as the Natesto trial, are not based on level 1 evidence. Some of the limitations include the study's lack of control arm, they are non-randomized, and they're non-blinded. Well, what's on the horizon? Well, an article was published in Urology Times this year, in January this year, and there's a study being performed looking at oral testosterone and the impact of sperm production. The study is being performed from the Baylor College of Medicine with Dr. Mo Kara, and they're looking at men aged 20 patients aged 18 to 49. Each patient will receive 200 to 400 milligrams of testosterone undecanoate twice a day for 3 months. I believe they're specifically using the brand Kaisertrex, and they'll be performing semen analysis at baseline, 1 month at 3 months, to see changes in sperm counts, as well as changes in hormone panels, hematocrit levels, as well as IIEF scores. So that is kind of the next step in the fertility-sparing realm of TRT. Going to some of the more common treatment strategies to review. So clomiphene citrate, or Clomid, as we know, is commonly the first step in first-line treatment for men with testosterone deficiency who are interested in preserving their fertility. And this is really due to a very favorable side effect profile, the kind of oral route, and as well as cost effectiveness to obtain the medicine. HCG monotherapy is first line for hypogonadotropic hypogonadism, or hypergonadotropic hypogonadism, such as Klinefelter syndrome, could be considered as well. Typically perform a serial increase in HCG monotherapy, starting at 2,000 units to ultimately 3,000 units 3 times a week. And we could consider combination of TRT, either a gel or injectable, with 500 of HCG 2 to 3 times per week as a combination treatment. It's important to note, I typically reserve aromatase inhibitors for men with a TE ratio of less than 10 to 1. So in conclusion, alternative testosterone therapies is first line for men with symptomatic hypogonadism who are concerned about their fertility potential. Select patients may benefit from a fertility-sparing exogenous testosterone therapy approach, and further studies are really needed to evaluate fertility outcomes in men who are on a combination of exogenous testosterone and low-dose HCG.
That was great. Thanks, Dr. Asanad. I really appreciate your talk here today on an important topic. I'm wondering if you could share with us your thoughts on men who come in and are just very far gone down that pathway. Men who maybe have been on high dose anabolic steroids for 5-10 years, have significant testicular atrophy. Do you have a preferred approach with them at this point? And if you have to use multimodal therapy in them, do you have a thought on the proper order to really drive their testicles?
Yeah, it's a really, really good point. Really good question. I think it really also depends on, the patient. Some are willing and, want to play ball. And I think typically the first line I would recommend is, how serious they are about optimizing their fertility, if they have a new partner and want to achieve a pregnancy as soon as possible. HCG monotherapy is the preferred approach. Some men who may be on really high doses for a long period of time may not be able to accommodate that initially. And so we can do a combination initially and try to get them to monotherapy. And if we can get some sperm in the ejaculate, which we can in the majority of men, they can freeze that, use that for IVF, and go back to their sort of therapy. I do think it's important to keep an eye on their FSH levels as well as we track these. Recombinant FSH plays a key role, but as we know, it's incredibly expensive and difficult to get. And sometimes adding, I think, clomiphene citrate in the mix can help stimulate the pituitary to release some FSH as well, and that can be kind of a more cost-effective approach.
That's great. And then circling back to the different therapeutic regimens you were discussing, can you talk a little bit about, number one, target levels of testosterone production, just to specify that a little bit, and then also how do you track these people clinically? Get a little bit more information about that. How often do you see them once they're on, what you'd regard as maintenance, and what kind of blood work are you doing for them over time?
Sure. So, the kind of guidelines recommend at least over 300 to be in the kind of normal range. I think from a fertility standpoint, I think that's just really the goal. Obviously, we want to see symptomatic improvement. I think I try not to really chase a number with men, but I think men who may be still mildly symptomatic and have maybe in the low normal range, I don't think there's any harm by optimizing their dosage further and getting them to a high level, such as 450 to 600 is kind of the guidelines recommend as a target level. And really, if they're doing well on that standpoint, we'll keep them there. But if there's really no difference, then I try to counsel them. It's unlikely to be a testosterone issue for them. In terms of kind of follow-up, I'll typically see men about every 4 weeks until we can get them at a good dosage. And then I'll usually see them every 6 months with blood work, and we'll track their testosterone level. If they're over the age of 40, we'll track their PSA, track their hematocrit levels, as well as their liver function enzymes.
I have a few more questions, but maybe we'll open it up in case any of our colleagues who are with us today live have any questions or comments. Great. Okay. So circling back, you mentioned the oral therapy, and I don't know that any of us have much experience with it,
Yeah.
but you probably have some perspective on it at this point in time. These therapies have just recently been approved by the Food and Drug Administration and provide a different alternative for patients compared to the forms we're used to giving, namely topical or intramuscular or pellets. What are your thoughts about that? You presented some interesting work by Dr. Kara that was, kind of highlighted in Urology Times. Do you have a personal perspective on that and how you're looking at the oral therapies at this point and what kind of a role they might have in your practice?
Yeah, I think they're a great option. I think folks in the U.S. are used to taking tablets and capsules, and while injections work well for many folks, maybe initially they're not, receptive to it, but I think most folks would like to take an oral medicine. And I think historically, it was very challenging to get these medicines like Jatenzo, and, was typically not approved unless very certain circumstances. I think it's becoming a little bit more commonplace now because this one brand, Kaisertrex, has kind of eliminated insurance from the prescriptions, and it's really just a cash pay prescription from specialty pharmacies, and I think it's about $140 a month. And so some folks, they're paying like $60, $70 for their injectable testosterone. I've met some folks and are totally fine to pay a little more to take an oral medicine. I think that works well for some and doesn't work well for others. Based on my experience with some of the medicine for the patients who, want to try it, typically you need to use the kind of higher end of the dosage for it to have symptomatic improvement. I think the low doses don't work really well to get guys symptomatically improve and levels improve. So it's typically the 400 milligrams twice a day is kind of what I've seen, or at least 300 milligrams twice a day. And it's kind of really a daily consistent basis that plays a key role. And if you kind of miss a day or so, just like the gels, levels go down really quickly.
So why don't we pivot to another clinical scenario? So sometimes we'll see younger guys who maybe they're in a relationship, maybe not, but have not yet entered that phase of their life where they're trying to have children, but do plan on it maybe 3-5 years down the road. And they have objectively low testosterone, and you can't find any anatomical correlate that you could address, and they feel bad. They're symptomatic, and they want to go on therapy. And so, do you preferentially start those folks on testosterone? Do you go with the alternative therapies that you highlighted? How do you approach those people clinically?
Yeah, I mean, I think I always try to counsel them on lifestyle factors as a first step, especially if there's really things that are very obvious, like weight loss, improved kind of diet life factors, other things that could really improve their natural testosterone production. I think I've met a few guys, in the past few months who just educating them about that really had no idea that can improve their levels. But for folks who want to start, medical therapy, I usually just still push for a Clomid medicine as a first step, and really kind of counsel them and kind of push them towards that. Because the last thing I want is them to come back and kind of have any sort of regret that, they're infertile and maybe we get their sperm counts to improve, but it's never really where it was, and they never get back to their baseline.
Yeah, it's really remarkable how many patients are out there that still are prescribed and administered exogenous testosterone therapy, and the conversation about the potential effects on fertility just isn't occurring by these providers. You would think that word would be back to the providers by now, that they just have to talk to their patients about this issue before they start the patients down that treatment pathway. I'm sure you're seeing plenty of that in Southern California as well, just as we do here in Chicago, right?
Yeah, absolutely.
Yeah. I guess one last final wrap-up question. If you had pearls for our colleagues, the best pathway forward after all this review you've done on this topic, you've guys come in, he's azoospermic, he's on 100 milligrams of testosterone every week. Any pearls for the audience, the live audience, and people watching us down the road, as brief thumbnail takeaways and best practices for taking over the care of that patient and guiding them towards fertility and paternity. What were your takeaways for the group here today?
Yeah, so I think the first part is just really kind of educating them and really not trying to poo-poo the person providing the medicine. I think there's really not a good place to do that. And I think it really just works on their lifestyle. I mean, I've seen a few guys who are really high functioning, super functioning guys. I mean, they're young, they're on testosterone, and they're not really willing to come off of it. And, we talk about first line would be to switch them to something over like Clomid, and they may not have the best kind of symptomatic relief like they were on testosterone. And you don't want to. You want to be very transparent with them about that. And so some guys are totally okay going straight to HCG. I think they can get a lot more symptomatic relief with that. And so that's either one of those is a great option. So I'd say takeaways, typically start with Clomid, 25 milligrams daily or half tablet daily. If the cost is really an issue, you can, some folks do dosing 3 times a week. That's also an option. But I think for guys who are on exogenous testosterone, are used to it, they're high functioning, and they may feel a crash with even on Clomid, having them on HCG may be a good idea, or at least trying to convince them to have concurrent therapy.
That's great. I mean, and I think we all see that where our patients who are having that exogenous testosterone removed and go on what they regard as being suboptimal therapy, a lot of them just won't be compliant because they can't function. They feel so depleted when they go from having really robust testosterone serum levels to very low levels. So I think it's important for us clinically, I completely agree with you, to be there with our patients and make sure we're monitoring not just their testosterone levels, but how they're doing clinically, because it is a big change once those levels are stopped. And I would just highlight one more thing that you really focused on in your talk and mentioned nicely, and that's not forgetting about FSH. And that's a critical ingredient for spermatogenesis for many men in this situation, and they may have persistent FSH suppression even after the testosterone therapy is withdrawn. So you mentioned recombinant FSH therapy as being a necessary ingredient in these folks, and I'm glad you mentioned it. Couldn't agree with you more. So with that, Dr. Asanad, I just want to thank you so much for taking the time to join us today for this session. I think we all learned a lot from your talk, and we're really proud of you for the work you're doing in Southern California and at USC. and look forward to many years of collaboration down the road. Thank you.
Thank you so much. Thanks, Dr. Brannigan. Thank you for everybody for being here. I appreciate it.